Hey everybody, welcome to this week's Dental Up podcast. This is Sean Keating here. I'm with Jack Edwards. He's our Director of Education here, and we're real excited to have Jack on board with us today.
Happy to be here.
Good job, Jack. You know, I like to start off talking about like sports and stuff. It's kind of weird. It's just I'd rather just do sports and not really talk about dentistry myself sometimes. But now, big thing around here is the Lakers. You know, I'm a big Lakers fan for years. Last few years it's been pretty tough. You know, cringeworthy watching them. It's just been horrible watching Kobe's career wind down and him just shooting up a gazillion shots and not being quite the player he was. Yeah. But so it was kind of neat to see him leave actually last year to get us back in to see what we're all about. We got a good crew of young guys, pretty neat guys. Randall, Delangelo, Russell, the Ingram kid, but just kind of a neat core group, Nance Jr. So we're excited about that. We probably need a really good big man and a couple other guys. We got Luke Walton in this year, which is a great young coach. I think everyone's really going to rebound around him. But it's something, Jim Buss, one of the owner's son, that died. Dr. Buss died a few years back, and his daughter Jeannie runs the team. Mm-hmm. And then, there's like 6 siblings that they all own it. And that's kind of neat how he set it up. But Jeannie's kind of in charge, and she's let her brother kind of run basketball operations as the president for the last 3-4 years. And they haven't really done it. So big thing came out with Magic Johnson becoming the new president. And that's pretty cool, as long as he's not just a cheerleader, that he'll do more than just kind of be the face of, he needs to get in there and really make a difference. But so exciting in Laker Nation to have Magic back. And then we got this new kid, Rob Pelinka, who's taken over as the general manager. And, it was Mitch Kupchak since like 94. He's been a Laker, and he's been there for a long time. They also got rid of Bob Black. He's been there for like 35 years, and he's been the spokesman. But they kind of cleaned house, and they're going to bring in this Pelinka kid. He's actually he's kind of an agent. He's an agent for Kobe, used to be Kobe's agent, and some other big guys. But that's what they're going to. You really got to know about contracts and how to work in the NBA and stuff, and to make things happen, to find talent. And the guy, I don't even know the guy's name over at Golden State Warriors, he's really made a difference there. Kind of the same kind of scenario where this guy didn't really have any basketball, general manager experience, but he came in, just doing a great job with the Warriors. But so this Pelinka kid looks like, he looks like a Rob Lowe type guy, man. It's like, what's this? But he's a younger guy. I think he's in his mid-40s. And so it's kind of exciting to get back to Laker. It was such a big thing for so many years. In the last 4, 5, 6 years, it's just been, I hardly even go out to Staples Center anymore. And it's just like, kind of tough. But so we're excited about Magic. Also, March Madness coming up. We got, UCLA. I'm really excited to see the Bruins get back into dominance like it was back in the early days. They got this Lonzo Ball kid that the dad's kind of a freak, weird, dad. We all love our children, and so it's something with this Ball kid. He has 2 younger brothers that go to Chino Hills or whatever, and kind of real big phenomenon here in high school basketball, these brothers. But like the dad, he's one and done, so this kid's a freshman. Makes a difference, does a lot of assists, pretty awesome ball player. But his dad's comparing him to Steph Curry and saying that he could be better than Steph. If they switched teams, he would do better. It's like, come on, dude. We love our children, and like my boys, I thought they were going to be the next Walter Payton, and but when you're 5 foot nothing, 100 nothing, you ain't going to be no NFL running back. But so it's something. We love our children. We think they're going to be in the big games and all that, but at the end of the day, 99.99% of all high school athletes don't go on to that pro level.
Unfortunately, that's very true.
That's true.
Very true.
Don't you have like your nephew or your grandson? He's like a swimmer or something?
My grandson, yes.
Tell me a little bit about that.
Oh, he's 12 years old, and he is qualifying for the Junior Olympics.
Oh, you're kidding.
And he is qualified in 5 events, and I believe the 6th one was about 2 weeks ago. He actually medaled in the backstroke. So with that, we're real excited for him.
Oh, that's so cool.
He's doing phenomenally.
So he's going to be our next Michael Phelps?
Well, you would think.
You
would think. He's already got a foot his feet are like flippers.
Oh, you're
so,
kidding.
Yeah, he's.
You know,
He's doing
that's
very
a big thing for collegiate to go to college, to get a scholarship.
Very much so,
and if that can get your ticket in there, that saves your whoever a lot of money or grandpa, it's a neat thing. I always told my kids, the only way you're going to go to college, you get a scholarship. No, that's a little joke there.
So my main objective when I go to be with him, other than to cheer him on, is to photograph him.
Oh, okay.
And I do have a couple of samples that I bring, if I may show those.
Oh yeah, absolutely. Jeez, he looks like a man. He doesn't
Here
look
he
like a
is doing
12-year-old.
doing the backstroke.
The guy's got a full goatee. No.
And, and here he is doing the butterfly.
Dude, he's got a big, long arm
Isn't
span
that?
there.
Isn't that? Yes. So we're very proud.
You can't really have those
Overall.
T-Rex arms to be a
no.
swimmer, huh?
No, not at all.
Oh, that's awesome, dude. Well, that's great. Hey, I hope he goes all the way, and I hope we're watching him on TV someday. Well, good job on that. What about, I heard something too, we'll get into the dental thing here. I just want to get through. I heard like NASA just discovered like 7 planets out there. And not just weirdest thing in the world, but they found 7 new planets, and they think there's like life form and stuff. And
That's what I've heard.
that's
This is what I've heard.
That's
Yes.
kind of makes you want to pray to God more at night. I think if there's people out there living on these planets, and it's similar to Earth, I guess, and it's just it's the whole light years of how quick. I don't know how they do it, but it's just something. It's a pretty amazing thing after all these years we've been on Earth and millions of years, this and that, and then you think about us, only United States, a couple hundred years old, basically, and it's just. But the new things coming out, it's like 40 light years away from what I hear. And that's like, I guess, I don't know, light year. I'm not a real smart guy when it comes to that. But just, man, to discover 7 new planets that are similar to Earth, that they pretty much sure there's life on it. And it's kind of weird. I mean, it's just kind of scary that what we really don't know what's out there. And that's why you got to have faith, maybe. That's what I do. Go to bed and say, please, Lord, help us. But, okay, enough of that. Let's talk a little dental. That's what this is all about. And, Jack, I've known you for over 30 years, man. That kind of ages us a little bit. But, you've been doing this forever. And you're like one of, I think only have 700 master dental technicians that are actually masters in the United States. And I think you're like a fellow. It's
a fellowship, yes.
That there's only like 40
of us.
40 of you. And I'm just so thankful that you're here with us, because you pretty much retired, and I kind of talked you out to come back because, I'm a fixed guy. You got fixed stuff for the people out there. A lot of people know, but fixed is it's fixed permanently in your mouth. And, your specialty, although you do everything, but your specialty really is removable. And with us here, I've always been a fixed lab, but several years back, I had to start a removal department so I could become full service, because a lot of my dentists, they would use me for my fixed work. They'd use me for the crown and bridge, and then when I had removable, like a lot of times you'll go 6 through 11, and beyond that, we have to do like a semi-precision partial, put a PD or an ERA, and then you do that. And then so many of my doctors would say, Sean, I hate to send you the fixed work, and then I got to send it off to a removable lab to do it. And then when your removable and fixed don't work together, it's a freaking nightmare. Mm-hmm. And it's even a nightmare when we work together, that if we're not on the same page, removable brings me a lot of headaches. It brought me a lot of gray hair back in the day, because I don't like doing it, to tell you the truth. But it's what we have to do. And a lot of people are edentulous. We do upper dentures, we do lower dentures, we do partials, we do a lot of implant stuff. There's a lot of the 4-on-1 stuff. And, right now, we could talk for an hour on that or more, but I want to go through some things and just let you talk a little bit about, let's say just on dentures, when a case comes in, how we kind of go through and do the things. But then also we'll get through and just what a dentist can do to help us have more predictable outcomes on the removable type situations. Getting impressions on, ridges, and getting proper impressions that are accurate. But let's go ahead and talk a little bit about on our denture process when it comes in, and how we go about it.
Certainly will. Of course, when a case comes in, sent in by a dentist, usually it's with Impressions, usually an upper and lower if we're doing a full set. There might be a bite involved in there, and hopefully there's a Facebook, which we can then utilize to set up the case on an articulator. With that, it starts our first QC. We're actually QC. This is very important that we communicate very closely with our clients as they send in the work so that we have a better understanding of exactly what they're looking for in a case. So with that, we might pour them up. We'll then QC the models, the cast, to see if they meet the criteria that we need to have to do a good, successful case.
What's the problem with the cast? We get voids or something, and maybe certain ridge, alveolar ridge, or, okay.
There's a lot of that. There's a lot of that. We actually need, if we're doing a maxilla, we need to have the palate. We need to have the flanges, the all the way down to the vestibules, as well as the hamular notches in the posterior. With that, we can it starts us off in the right direction. We're able to then create a bite rim that is more to the standards of that. Okay. With the lower, we do the same thing. We have to have the retromolar pads in the posteriors, as well as the flanges, and definitely with the tongue out of position, if all possible, as deep flanges as we can get into the vestibules of the lower ridge. So, with that being said, those are the first things that we need to do. So it's
quick on that though. The tongue is such a beast to get that.
Yes.
I mean, what do? You almost hold it with some hemostats or pull it apart, or
believe it or not, I have seen that. I don't recommend that.
That's crazy. I mean, I got a wild tongue when I'm in there. Like,
well, I've seen just about everything. Being also an in-house technician too, so I have that full extension to that aspect, but. The tongue, usually we ask the patient to raise the tongue up towards the top of their mouth. That's right. And with that, it pretty well clears it out. And then we can make sure that we get the impression material to get inside of that area so that we have a full impression of that complete arch.
Yep.
This is very, very key. It's not just taking a horseshoe impression. It's nothing like crown and bridge. Yeah. This is removable, and this is what I'm trying to. We work with our clients because phone calls are very, very important.
Yep, absolutely.
That is the key. We have to have collaboration and communications. We got to create a rapport with our clients. So we have the manager, Jim, and we have one of his assistants is Brian. Mm-hmm. Both of these gentlemen are on the telephone all the time.
Absolutely.
We actually use probably more phone calls and more phone work than the Crown and Bridge guys do.
Oh, I know. You guys do.
Because these cases are not that easy. One would think that they're easy. No, it's not that case. These are more complicated. And the kind of work that I do, dealing with implants and all on four kind of scenarios, they take a lot of time and precision work that we have to do. That's why it's part of my other job there, other than being a director of education.
Yeah,
so
you put a lot of fires out and you're on the phones a lot. And it just all gets back to the darn impression. I mean, to go beyond that, we have a lot of things we could do to work on, things there, but the impression itself, it's the foundation. And if we can't get that, what do you find like best? Old school alginate that just flows in better, or what?
Well, actually, I still like the polyvinyl siloxane.
Okay.
My preference is a two-stage technique. You could actually almost use like a lab putty or a very heavy body material in a standard stock tray. Take that first, remove it, then we can cut out, if there's teeth in there, we can cut it out. Say for an immediate, we can cut out the areas where the teeth are and everything. And then we re-inject a light-bodied impression material, replace it, and that gets everywhere. Then we let that set up. As we pull it out, we have a much, much better accurate impression.
Oh, that's so cool. We should do a little video on that, even here, because how many of our guys actually do that, where they cut it out maybe 10%, 20% or more? It's just hard to say probably, but if we could get the right technique that will give you 95 to 100% accurate result, I think they want that in a way.
Will eliminate those pulls that we see and the drags and the distortion in the cases that we're dealing with. Now, even though this is just removable,
Yep.
but we want to be very precise.
Absolutely.
Because we're looking at we want good adhesion,
Yep.
eucostatic
want to fit.
adhesion.
I mean, we always say
want-
socks on a rooster. We don't want that. We don't want them flopping around where they have to do they still use that gunk they put in there for adhesion? Remember that? What is that called?
Well, to tell you that, well,
is
you're
that stuff
talking,
called?
yes, there's
Super
still,
grip, or what is it called?
Oh, they got a lot of that. You're talking about all the ones that are
On
you can
TV
buy.
back in the
Yes,
70s.
right. You
What's
can
that
buy
called?
at the drugstore and
What's the
all
name
this
of that
stuff.
stuff?
Polygrip.
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 They got a polygrip, and they got their things in the side. Honey! Imagine that waking up in bed. Hey, get your juice out. Okay. Oh, Jesus.
Unfortunately, that's the stigma that we have to deal with.
Yeah.
Where
But
a lot-
nowadays, with the right retention, though, and like just like a doctor when he preps a prep, if he gets the right angles, you almost don't need cement. I mean, the friction, everything holds it. And especially if you can get a denture that has got all your borders and boundaries all in the impression, these things are going to lock and load in there.
All the time.
All the time, so
All
much
the time.
better.
All
And
the time.
you wonder why patients complain about this and that. Well, it's probably from the dentist not giving us a super accurate impression that I can come in and, because we're sucking these things down, vacuum. I mean, it's what we get is what it's going to be made to. So if we're having gaps and this and that, it's not going to be as retentive as it can be. And that's a whole thing too. We always said, hey, let's sink an implant here and here and then lock and load that denture, and it's still not fitting. You really need that awesome impression. You don't really, I mean, it's great if you can sink a couple implants to lock that denture in. But a lot of people can't afford that. A lot of people can't do that. And if that dentist could give them a smoking hot impression for us, our dentures are really good, I think,
Very much so.
when we're doing them right and when we're getting the right stuff in. Okay, go ahead. I'll shut up.
Well, all in all, what I'm looking for in our relationship with our clients is that the client, we need for them to provide us with a clinical treatment plan. A lot of that has to do, now we don't necessarily need to know their medical history, their dental history, or their financial, but mainly it might involve the patient's wants and needs, what the doctor is looking for in the case. And we need to know, actually, if it has to do with anything with implants, we need to have a surgeon's letter that tells us in detail what the surgeon put into the mouth, what the name of the implant is, what the style of the implant is, the size, everything, because from there we can help the restorative dentist build the case.
Yeah.
We can help them look at the parts that we would need to have. Because a lot of times we get the case coming in that is only at the fixture level.
Yep.
Well, we're restorative. We work from the tissue up. Anything that's below, we're sort of at a loss here a little bit, because we can get the parts and we can get the sizes and blah blah blah, but we can't put those in. We need the restorative dentist to put those abutments in, and that's where we restore from the abutment level up.
Are we getting that with most of our guys, or a lot of times
A
not?
lot of times not.
Yeah.
So in a sense, when we get a case, it's already in the middle of the case. What happened to stage one?
Yeah.
The very beginning. Like for an example, here's a case that I've done an immediate, where I've done model surgery, replaced all the teeth, and then I'll be processing this, and this will eventually go in, and I'll actually make a surgical guide from here, and this will all go in towards implant placement. This will actually go to the middle of the case, of the series, the workflow, in the conversion. And then the surgeon will utilize this for the guides, setting everything, placing the abutments, and then we should get it back at that time. A lot of our cases that come in never got to that level. They've already started the case, the implants are in, and now we're in the middle of this workflow. I usually at this time have to say, sometimes there's not even teeth set.
Yeah.
So we got to go back,
Oh,
and sort of start. We have to start over again. Start setting up teeth. We have to have a blueprint. We have to have our
set
foundation.
the 2 teeth and a bite block and send it to them and say, "Give me something. Show me where their midline or their nose is, and let's go off the face." I mean, it's
Sean. It's a lot of that. I know. It's a lot of that. I've been very, very fortunate to have been an in-house technologist. And also I work with a few dentists that actually invite me to their practice, and I work with them and the patient. And so now they actually have the representative of a laboratory.
Yep.
They're talking about the technical aspects of the case. So when we bring the whole team together,
it just goes so great.
It's phenomenal.
I mean, I do that just in fixed with doctors when we do it from the beginning, and we get stump shades and we do the temporaries or the custom wax ups. When we do it right by the book, it's just a bitchin' feeling, man. It just goes so good. I just did a case. I have a friend that's been my friend since junior high school, even 6th grade on up. And the dude's teeth are just always kind of messed up forever. And all these years I was like, "Mark, I'm going to make you these teeth." So we did it on Monday. We flew them out on Monday, but we already had the study models. We already looked at them. We had all the x-rays. And my doctor out here, I sent him out here because I wanted, my doctor to do it for him. And but we did this on Monday. We flew them out Sunday night, but we had all the stuff ready. We had the coys, set. Everything was just done by the book, and it was just so much easier than to go by the seat of your pants. So we had his x-rays, we had his models, and we mocked up and did the wax ups, proved everything. So we flew him in Sunday night. Monday morning, we went in there from 9 to noon. He prepped it up, 20 teeth, 10 up top, 10 below. The temps went in with just very little on the occlusion. It went to our lab, and I always do these over the shoulders, like here where we prep it today and then do it tomorrow. For dentists coming, we have like 10, 15 dentists that come around the table here, and we do these patients. But it's always been just an upper or a lower, so we're always 10, 12 teeth, and we send it off to the lab. And, we have several people have to go through it, pouring it up, and then we have to design it. If it's Emax, we'll design it, then we'll press it, and then we have a ceramist have to do it all the work. So with this one, I'm like, that'd be no problem. So we prepped them Monday, 3 hours, beautiful preps, temps. I mean, the dude, his name's Mark Adler, my buddy. Mark, we're going to show your teeth to the world here in a couple days. We'll get the pictures out, but he was just so, he was in tears with the temporaries. And so we're out there 1 o'clock, we're eating lunch, and I'm taking pictures of, look at those teeth. Because his teeth was kind of like a bowl of jelly beans, before. And that's just, some people, it's what happens. And, they don't have a friend that makes teeth. So yeah. I did that, and then, went to the lab, but shit, it was tough because we usually, one ceramist will be there, it comes in at midnight after everything's done, then they can work on it. So we had to do it where I had to bring in 2 ceramists, so we had to dupe the posing because I had the one doing the upper and the other doing the lower because it's just a real time constraint. So we did it, come in Monday or Tuesday morning. He spends the night at my house both nights. So Tuesday morning I take him over to the doctor's office and put all the crowns in about 1 hour. And hour and 10 minutes total, bonding, all these crowns. It's just like night and day. But you know what? When you work together as a team between the doctor's office and the laboratory, there's nothing you can't do. And I could do roundies, upper lowers all day, every day, like clockwork. And just, it's so predictable when you do it right. The removable division, man, you guys up there, I work so hard to do this stuff in the partials, and we don't really make any money. There's a lot of time involved, but it's a lot of backpedaling because the whole thing is not getting the proper impression or not getting the proper design or not knowing the exact hardware. And the doctor's like, if you could just stop and slow it down and kind of give us the predictable, 1, 2, 3 on this, removable can go and be predictable, be profitable, and be very joyous to do it for patients because so many millions of people out there that are edentulous that have no teeth, and they think all they got is an option of implants, a 4-in-1. That stuff's really expensive. A denture we could do real quick that could fit like a glove if it's done right. But it's just something that I want to get better. I want to do more almost like Skype stuff when we're seeing and we could show the doctor when we're talking.
Exactly.
We have the video, we have the technology. Doctor, look what I got here, man. Look at what I got going here. can't do this anymore. You got to give me this, 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 and hopefully we don't piss them off enough that sometimes doctors are like, man, these guys are too demanding for this. I never had my other labs do this, and it's like, you know, at the end of the day, this is a business, and we'd rather do it right the first time because we do remake everything at no charge. So when we start a case with a dentist, if it doesn't go right, we have to redo it, and that's just. I don't want to redo it as bad as the doctor doesn't want to redo it, and we know that. And so we don't have a lot of dentists that are doing it on purpose. They're doing it because they just have been used to doing it, and it gets by. But if we can, the little things help out so much. Tell me a little bit about the Coys analyzer there that we're doing.
This is the Coys analyzer. It is not an ear bow. It is a face bow.
A face bow, okay.
This is a face bow, what we would call a face bow. Excuse me. And it utilizes only the upper maxilla. The patient, we have the patient, see this fence right here?
Mm-hmm.
We put the two centrals in the midline right in this position
So you
here.
try to get them behind that.
That's right. And then we have this vertical rod goes right into the facial midline, not necessarily the
so
dental.
we're not like cockeyed teeth. That's where the teeth are always
Exactly.
like this. And
Exactly.
like it's called a slanted reverse smile and
That's
stuff.
right. That's
So
right.
that has it. Put that up.
So that
towards
comes
the
right on in
look
here
at
like this, comes right on here, and it follows the midline of the face. Now this is what, in removable, this is what we deal with. Now in the fixed department, they need to have this more in the midline of the two centrals. Usually is where we're starting, unless there's a slight. So that could be a skeletal defect from one side to the other, but it doesn't matter. That's where it starts in fixed. In removable, we can get it right in the middle of the face.
Yeah, because you could move it
Exactly.
wherever you want.
I suggest that the dentist with a dry erase pen put a dot between, or right here between on the forehead,
You'd be
between
like
the eyes.
like from India.
From India, basically. There you go. And one here in the middle of the chin. And not necessarily the nose, because the nose could be a little bit of the left, a little bit of the right. Okay. And then if they want to put a piece of floss, drop the floss down to give them a visual, and then we place this right on in, right to that line. So this is very key, making sure that we have the same space on both sides of the lateral arms. And the lateral arms are following the camper's plane, which is from the ala of the nose to the trachea of the ear. That is usually parallel to the occlusal table. So we need to have it this way. We don't want it going down.
Yeah.
I can hear my mentor, Leon. He says, Jack, teeth don't go down the throat.
Yeah.
Okay. So those are, I have to live with these voices. Okay. So
No, that's okay.
anyway, but all in all, this is a very, very nice. From here, we can take, we put impression material on here, replace it. So we do a dry run first, and then we place the material on here and go back in and get this to set up, and so now we have that. From there, we can remove that, and this then goes to our setup table.
And this is all on our Panadents, which we
All on the
work with.
Panadent. This is set at 0 in this case, and then we can bring this down, and it'll fit in here just like this. That's the way it fits in.
Let's pick it up and turn it towards there, and then
See it just like this.
turn it
And
that
see,
way.
you can see where the midline is
Absolutely.
right there.
So it goes right between the centrals, and it just helps us so much, doesn't it?
Well,
It's just amazing.
what's nice about this, then we can mount the upper cast. From that, we remove this and then place this is a setup table. A waxing, actually they call it a waxing setup table. This can be used for fixed and for removable. And then this comes back in and it shows exactly
Yep.
where our teeth should be.
Yep.
And notice how I marked them. Now this was an immediate, so I marked the existing teeth. Notice that I set the teeth up exactly in those same marks.
Yep.
See that? And her teeth were flared this way. I brought them back.
Yep.
And it shows it right here. I'm back a couple of millimeters.
It's just such a great tool.
Isn't this neat?
It tells you overjet, include everything where you want it, midline. It's kind of a neat thing.
Very much so.
John Coys, thank you for that. Dr.
Yeah.
Coys at the
He
Coys
did,
Center out in Seattle. We love him. He's just made our work fixed so much easier, let alone it's for removable too.
It's
Nothing
fast
tougher.
and it's quick and it's very precise. Well, we're not 100% exactly precise, but very, very close.
Absolutely.
Remember, we're also sitting on tissue that sort of has a little movement as well. So,
Well, Jack, I want to thank you. Tell me real quick before we go off, what do you think about the future of dentures in the CAD/CAM area? You know, there's a few systems out there, and it seems like I got to jump through a bunch of hoops to get them digitally, but it does work, but it's pretty costly for us. And when I'm selling a denture for this much, and it's actually cost me, it's kind of tough, but it's kind of like the old thing with, technology. It's just starting off in that. So, but tell me a little bit, what do you think about some of the removable and the digital stuff?
well, I myself agree that we're not ready.
Yeah.
It's not. It's close. Will it be our future? The answer is yes.
You think so? Huh?
Yes, it will be. It will be. That's just the way we are.
Yeah.
We will perfect it. It's already in a movement.
Yeah.
It will come to be. Cost would probably come down.
Yeah.
And from that, as we're using it now, we do use some of CAD/CAM now, but we're using it as an accessory. They make our accessories. Yeah. In other words, if I'm doing like an all-on-4 and I need a titanium bar, it will help me make my bar to attach directly to the implants. That's a must. That's what brought me back into doing that level of work. Before we used to cast it, wax it and cast it,
Yeah.
solder, cast, it was terrible.
Oh, that's
and
tough.
the precision that we had to have. Now we do it CAD/CAM, and these bars just drop right
They
in.
really are unbelievable.
Unbelievable. So we use it as an accessory more than anything. Also, CAD/CAM also helps us in making our partials too.
Yeah. Oh, that's working though. Kind of.
That's
pretty good. I really like our partials
Absolutely.
being done
Oh,
digitally.
have you ever seen it? I'm very
they-
critical, and I gotta sit on top
They
of our
fit
rests
like
and everything,
something
and I'm
I'm-
looking and I'm going, oh, this is too nice.
Yeah.
Too nice.
It really
Very nice.
is. It's amazing. So
Very,
we're
very
excited
pleased.
about it. And as it gets further along, we'll pass it on to our customers and say, because we're never been the flavor of the month here. You know, I have so many vendors that want me to use their porcelain or their partial alloy. And we use what is the best out there and what we find works best with our clients. And that's what we use. We don't use because, hey, Sean, I can give you this 30% cheaper. No, I find out you get what you pay for. And technology it can't just come along and you can't jump on board because in a year that could be gone and you could be having a lot of nightmares. So I've been through the art glass. I've been through the different things in the dental industry that have bit me in the you-know-what. And we're not going to do that when it comes to our company here. So we really look out for the dentists and the patients because at the end of the day, the patients pay our bills. So we got to take care of these guys, make them look good, and try to get it where their experience with the dentist is a happy one. I want to change the whole thing with dentistry. Like when I was a young kid going, it was like, the dentist. Now it's kind of a neat thing. You don't feel pain anymore. You don't feel nothing. Even my buddy Mark the other day, that little wand anesthesia, man, that is just the wickedest little thing. That's a little thing that goes in there and then just dispenses a little bit of anesthesia in there, and no big old shots up into your eyeballs, and it's just crazy. And and your lips aren't numb or nothing. You're not going to. We were eating an hour later after the dude got prepped 20 teeth. We're like, okay, let's go over to Benji's. But anyways, okay, Jack, dude, you're the man. Thank you so much.
Absolutely.
I know you could talk forever on this, but we try to keep these short and sweet. Try not to put the guys to sleep, but I want to thank you very much, everybody, for this week's podcast here at Keegan Dental Arts. If you could go on iTunes and subscribe. I guess that's like a like in Facebook. I don't know why we need the likes. I mean, it's just, I don't know. But if you could, go on iTunes because that's where Dental Up is. And we kind of went offline a little bit for a few months. And we're trying to, build up the guys, listening and just let the other doctors know that we're back doing this and stuff. And but if you could go on to iTunes, subscribe to the Dental Up podcast for us. Leave a review if you could. If you can, go on Google, do a Google review or whatever that is. Say good things. Say whatever, say what you feel. But I want to thank you all again, and really appreciate all the doctors out there that are working with us and have worked with us. And we thank you for everything. Bye.